Annyeonghaseyo, everyone. Good morning for you. For me, it is currently evening in Boston, and I'm very pleased to have the opportunity to speak with you all today about ST2 and cardiovascular disease. I'm going to hide my webcam now, but I wanted to thank you for the opportunity to speak with you all today. And I'll now close the webcam so you can just see my slides. So I wanted to speak a little bit today about the use of ST2 in cardiovascular disease. And by way of introduction, we know certainly in the United States of America, and I'm sure in Korea, heart failure continues to be an increasingly problematic issue with larger and larger numbers of patients developing the diagnosis of heart failure. And of course, patients with heart failure have a terrible prognosis. But the prognosis is variable from patient to patient. Not every patient with heart failure has as severe a course as others. And so understanding which patients are at highest risk is of great value. In particular, understanding which patients are developing the risk for hospitalization for acute heart failure, which itself is associated with a substantial risk for rehospitalization and mortality, is, I think, of great importance, particularly if there's a way to identify and tailor therapies to prevent hospitalizations and reduce risk in those patients whose risk is rising. And that's where ST2 testing has become really of great value. Biomarkers in general are of interest for their ability to prognosticate in heart failure, and ST2 is a rather unique biomarker. This is a marker that has been identified in the cardiovascular system as being induced by myocardial strain. So the original studies identifying ST2 as a cardiac biomarker focused on which genes were upregulated when a cardiomyocyte was stretched. And of all of the gene transcripts identified, the one that was most highly upregulated was ST2. Now, we know that ST2 is found in the myocardium. We also know that ST2 is found in vascular endothelium. So if you look, there's expression of ST2 in the vasculature in atherosclerosis. It's also very strongly upregulated in the pulmonary vasculature as well as in the alveolar epithelium. So it's really best viewed as a cardiopulmonary biomarker with strong prognostic meaning in diseases involving these various organs. Biologically, the role of ST2 is quite interesting. ST2 binds to interleukin 33. Interleukin 33 is a hormone in the body whose role is to exert a favorable effect. Interleukin 33 blocks cardiomyocyte hypertrophy. And for example, this animal model, exposure to angiotensin 2 or phenylephrine, if you also administer interleukin 33, one can block the development of hypertrophy in this animal model. And indeed, if you look in both animal models as well as in human tissue, the way that ST2 appears to exert its effects in the body is that it binds and neutralizes interleukin 33. So IL-33 is a favorable effect. IL-33 upregulates various pathways in the body associated with tissue survival in the setting of stretch and injury, whereas ST2 in a normal situation gently downregulates IL-33. In the setting of excessive ST2 release, however, we see excessive apoptosis, cardiomyocyte hypertrophy, and development of a heart failure phenotype. So on the left is an endomyocardial biopsy with normal ST2 signaling, and on the right we see the effects of abnormal ST2 signaling with cardiac remodeling and the development of heart failure. And this finding in experimental models is exactly what we see in humans when we test ST2 in the context of heart failure. Now, there are different ways of measuring ST2, and I'm going to speak today about the value of ST2 for testing in normal populations, people who are at risk for heart failure. We'll talk mostly about its role in terms of testing for patients with heart failure. And then lastly, I'll mention just a few slides on the use of ST2 measurement in patients with acute ischemic heart disease. So first, why measure ST2 in the first place? Why bother? We have natriuretic peptides, we have troponin. Why bother with ST2 as a biomarker in heart disease? Well, the first thing is it's the testing of ST2 was facilitated with the development of highly sensitive, high-quality assays for its measurement. And what we've discovered over the years is that ST2 is quite unique with respect to the information it provides to us relative to N-terminal proBNP, BNP, or troponin. They're actually additive. In addition, ST2, unlike the natriuretic peptides or troponin, is much less affected by the age of the patient that we test, their body mass index, or kidney function. And this is important because older patients, obese patients, patients with chronic kidney disease, these tend to be the areas of weakness for natriuretic peptides and troponin. And so we have found that ST2 is actually just as useful in patients that are older or who are overweight or who have bad kidneys. So I think that that's an important advantage. Now, in order to measure ST2, there are different assays that are available. There's an automated ELISA assay that can measure ST2. This is more laboratory-based. In addition, there's a point-of-care assay, the Aspect Plus ST2 test, that provides results with a lateral flow immunoassay. And one of the nice things about this test is that it provides comparable performance to the ELISA assay. So I think that whether you decide to use the ELISA or the Aspect Plus test, as well as upcoming automated versions of the assay, we can be confident that the results are interchangeable. Now, what about testing in normal patients? These are patients that we might see in the office who might be at risk for the development of heart disease, but who do not yet have heart failure. We measured ST2 in the Framingham Heart Study, and what we found was that ST2 concentrations were a significant predictor of the development of hypertension in the future in patients who were not hypertensive at the time that ST2 was measured. So seen here is the likelihood for the development of hypertension across the various quartiles of ST2 measured in the Framingham Heart Study. You see that in the highest quartile of a ST2 of 25 nanograms per milliliter, above that threshold value, the likelihood for the development of elevated blood pressure in subsequent measures was nearly doubled. And that's important because when we look at the prognostic information for predicting onset of heart failure, we see very similar findings, which is that a value above the median concentration, once again, the median here is about 20 nanograms per milliliter, even when adjusted for all of the variables listed on the slide, concentrations of ST2 independently predicted heart failure onset in community-based subjects without structural heart disease, without known heart failure. So this really indicates value for ST2 for a primary prevention population. So we measure it in our at-risk patients in the clinic. We find it particularly useful for patients at higher baseline risk, such as those patients who might have already a diagnosis of hypertension or diabetes. We recommend measuring it once yearly. And if elevated, and remember that in the Framingham, the median concentration was 20 nanograms per milliliter. So this is a lower cutoff than we use in patients with heart failure. But if above that value, we are much more careful with respect to our assessment. We seek whether the patient's blood pressure control is adequate. We make sure that their cardiac risk factors are well managed. And we even consider the use of echocardiography in these patients, because an elevated ST2 in apparently well patients has actually been shown to predict ventricular remodeling over time in a Thai population study. So we find value for the apparently well patients. Now, what about in patients with heart failure? So the majority of the discussion will be actually in patients who've developed prevalent heart failure. And I'd like to start first with how we use ST2 in acute heart failure, and then I'll switch to its testing in chronic heart failure. First, one of the questions that people ask, is what information are we gaining by measuring ST2 concentrations in patients with acute heart failure? And this is an older study that we did back about almost 10 years ago now, looking at the predictors of ST2 concentrations in patients with acute heart failure. And what we found even back then was that elevated values of ST2 strongly associated with the presence of structural heart disease, including both systolic and diastolic dysfunction, but particularly strongly predicted by pulmonary artery pressures and right-sided heart failure. So it really identifies a patient population with a more decompensated cardiovascular structure and function picture. When we look prognostically at what ST2 tells us, this is a meta-analysis we just published about a year ago in JACC Heart Failure, looking at the various studies that have examined concentrations of ST2 as a predictor of mortality in acute heart failure. And what we found across all of these various studies, including studies from Europe, the United States, and Asia, was that ST2 in fully adjusted models was a powerful predictor of mortality in acute heart failure. Now, I would point out that the value that we used here, the ST2 concentration we used here, was the admission ST2 value, but there's more to this story that I'm going to mention in just one second. In addition to being valuable for prediction of mortality as a single measurement, ST2, as I mentioned earlier, adds to the prognostic information that we gain from other biomarkers. So one of the reasons why ST2 appears to be independent of the natriuretic peptides and troponin is because it provides us unique biological information. So they are additive for prognosis. So in this study that we did out of Spain, we examined the likelihood for mortality by 6 months among 200 patients with acute heart failure. And we measured NT-proBNP, high sensitivity troponin T, and soluble ST2. And in each of these categories, there's either 0 markers elevated, 1, 2, or 3 markers elevated. And in each of these categories, we have about 25% of the subjects that were admitted to the hospital. And what we see is that there's an additive risk prediction for patients when measuring 1, 2, or 3 biomarkers. So we can stratify risk to very low risk, 0% 6-month mortality, or very high risk, a 50% 6-month mortality, simply with those 3 biomarkers, which I think is very powerful and very interesting. Now, of course, one measurement of ST2 at admission is quite helpful, but it turns out we've found that serial testing, measurement more than once in acute heart failure, provides us even more information. And there are several studies that have shown this now, but probably the nicest one is the TRIUMPH study, which looked at serial measurements of ST2 in patients hospitalized with acute heart failure. And what the TRIUMPH investigators found was that either at baseline or by 1 week or so, 7 to 10 days after admission, patients that were likely to suffer a heart failure event or death by 6 to 12 months after admission, those patients that were more likely to suffer a complication had higher values on admission, but also had higher values at discharge. So serial testing in particular identifies high-risk patients at discharge where the discharge value was actually a stronger predictor of outcomes than the baseline. So what we recommend in acute heart failure is to measure it on admission in order to help make decisions about risk and triage. And here we use an admission concentration that's higher than we use in either chronic heart failure or in apparently well patients. So in acute heart failure, we tend to focus on the high-risk patients as having an ST2 value greater than 50 to 75 nanograms per milliliter. We measure it on admission. Then we do not measure it again until discharge. So we treat the patient for their decompensation. We adjust their guideline-directed medical therapy, and then we remeasure at discharge. And what has been found, of course, is that lower values by discharge are always better than higher. And certainly we hope to see a declining, a falling ST2 concentration. If it is possible to get a patient under 50 nanograms per milliliter by discharge, this is desirable. Certainly less than 75 would be, we would hope to see. If a patient remains above 50 to 75 nanograms per milliliter on discharge, they remain high risk and should be followed up very carefully after discharge. One of the nice things that I like about biomarkers is that they can then be measured after discharge. So we use them as a bridge from hospital to home now. So after discharge, measurement of ST2 in the office is possible. And indeed, the same study, the TRIUMPH investigators, then looked at the value of serial ST2 concentrations after discharge relative to outcomes. So these are examples of 6 patients after discharge, and you'll notice on the x-axis, the time from discharge is anywhere from about 6 months to a year. And those patients on the left side of the screen are those patients that were readmitted or died. You can see that the trends after discharge in those patients that were destined for a complication tended to go back up when patients were likely to suffer a complication, whereas on the right side of the screen are examples of patients who had a successful treatment without any events during follow-up. So trends in ST2 concentrations early after discharge are very helpful for identifying those patients likely to develop complications during follow-up. And this gets us to the chronic heart failure patients. There are many studies now that have shown the value of ST2 in chronic heart failure. This was another meta-analysis showing the value of ST2 in chronic heart failure, a single measurement, and even in fully adjusted models, ST2 was a strong predictor of mortality in chronic heart failure. Now, I want you to remember the first study in this forest plot, where the value of ST2 was right on identity. This was the VALHEF study. And we're going to come back to the VALHEF study in just a little bit. But that's the one study that stood out as not being associated with risk with ST2 testing using the baseline value. And I'll show you why when we get to those results. Importantly, when we look at the value of ST2, much like any biomarker, there's a cutoff that predicts risk. The cutoff appears to be right around 35 nanograms per milliliter. So in chronic heart failure, the cutoff of 35, whether we're trying to predict all-cause mortality, cardiovascular death, or heart failure hospitalization, seems to be right around 35 nanograms per milliliter. But of course, the higher the concentration in chronic heart failure, the worse the patient does. Now, one question that we asked was, what explains this risk? In other words, why do patients with higher concentrations of ST2 have a worse prognosis in heart failure? What we found was, in fact, that ST2 very strongly predicts ventricular remodeling in chronic heart failure. So if you look, there are independent predictors of remodeling, including ST2 as well as other clinical variables, non-ischemic heart failure, clearly associated with reverse remodeling, absence of conduction disease, a short time of a heart failure diagnosis. Lower ejection fraction is more likely to show some degree of reverse remodeling once therapy is initiated, as well as, of course, therapy, such as beta blocker therapy. So these are just, this is just an example of how ST2 predicts one of the major complications that is associated with prognosis in chronic heart failure, specifically remodeling. So when we see patients chronically, if they have a low ST2 value, less than 50, but even better if they're below 35, these patients are reassuring to us. We know that they are not developing ventricular remodeling, and therefore we're less likely to subject them to more frequent imaging, such as echocardiography. When we think about other biomarkers, in this study that we just published in the Journal of the American College of Cardiology, it's a very large patient cohort of more than 4,000 patients, we found, again, just like in acute heart failure, N-terminal proBNP, high sensitivity troponin T, and N-terminal and ST2 were additive for risk. And what we found was that patients with an elevated concentration of 1, 2, or all 3 biomarkers tended to have higher and higher risk for cardiovascular hospitalization, cardiovascular death, as well as all-cause mortality. So we feel actually that these markers should be measured together. Now, importantly, if you look at patients that have a low N-terminal proBNP and a low troponin T, but an elevated ST2, we see, in fact, that these patients are at generally lower risk, but their risk is still higher than those patients that have all 3 markers that are low. So even when a natriuretic peptide and a troponin are low, in this case, the cutoffs were 1,000 picograms per milliliter for NT-proBNP, 14 nanograms per liter for troponin T, and 35 nanograms per milliliter for ST2. Even if only ST2 is elevated, the risk is still nearly 2 times higher for all-cause mortality, demonstrating just how valuable ST2 is for predicting prognosis, even when other biomarkers are negative. So we come back now to the question of why the VALHEF study did not show value using the baseline value. And in part, the reason has to do with the fact that the ST2 concentrations in VALHEF changed quite substantially after randomization to valsartan. So importantly, in VALHEF, although the baseline value did not appear to be prognostic, if measured serially, in this case separated by 4 months, the patients that had a rise from low to elevated ST2 had a substantial risk, a near doubling in their risk for mortality over just a 4-month period if a patient had a change from low to high, whereas those patients that went from an elevated value down to a low value, their risk was actually quite low. So this just demonstrates the interaction between therapy and changes in ST2 and their ability to predict subsequent prognosis. So we have found that serial measurements of ST2 are actually much more valuable in chronic heart failure than a single measurement. In this analysis, we looked at the changes over a 3-month period, once again finding that a change from below to above 35 nanograms per milliliter during the study period was associated with a near 4-fold increase in the likelihood for heart failure hospitalization or cardiovascular death. In addition, these changes predicted ventricular remodeling, changes in left ventricular size and function. We come back to the TRIUMPH study one more time, and in this study, once again, the investigators examined the trends in ST2 over time compared to the likelihood for an adverse event. In blue are the concentrations of ST2 in patients that had an event. In orange are the patients who were without an event. And over a 6-month period, patients that were above 35 nanograms per milliliter, and in particular those with a rising concentration over time, were much more likely to suffer a complication of heart failure, either death or heart failure hospitalization. So the question then is, what do you do? How do you reduce the risk? Well, I've already shown you how treatment with valsartan lowers concentrations of ST2 and reduces the risk for a heart failure complication. There are other therapies that affect ST2 concentrations. There are other studies that have shown that other therapies reduce ST2 values and reduce their risk. I've already shown you the data from the VALHEF study. Mineralocorticoid receptor antagonists such as spironolactone and eplerenone reduce ST2 concentrations and reduce risk. And importantly, recent data from the PARADIGM study show that sacubitril valsartan, or Entresto, reduces ST2 values as well. In this study that was recently published in Circulation Heart Failure, treatment with sacubitril valsartan was associated with a significantly larger number of patients showing a reduction in their ST2 values. And in those patients with a reduction in their ST2 values, a superior outcome was seen. There are only 2 biomarkers in the PARADIGM study that have shown associations between change after treatment with sacubitril valsartan and improved outcomes. Those 2 biomarkers are NT-proBNP and ST2. So importantly, ST2, and this is change around that 35 nanogram per milliliter threshold, really seems to predict benefit from this therapy. So what we do in our heart failure patients, we measure them at each visit. We also will measure them if they have a change in their symptoms. In chronic heart failure, the goal value is below 35 nanograms per milliliter. So again, remember the different cutoffs. In chronic heart failure, it's 35 nanograms. In acute heart failure, more towards 50 to 75 nanograms per milliliter. In healthy patients, it's lower. It's more towards 20 nanograms per milliliter. In those patients with rising values or persistently elevated values, we try as best as possible to adjust their therapies. If they're eligible, we will switch them to Entresto. We will adjust their beta blockers upwards. We'll add mineralocorticoid blockers if they're not already taking them. We will evaluate them with echocardiography to look for remodeling. An elevated value identifies substantial risk, and we want to try to respond to that risk in turn. Lastly, there are other applications of ST2 besides the patients that have heart failure or those patients that are at risk for heart failure. There are now several studies that have demonstrated value for measuring ST2 for prediction of heart failure onset in patients with acute myocardial infarction. These are data looking at ST2 measurement on admission in patients with a non-ST segment elevation acute myocardial infarction, stratified as a function of an ST2 value of 35 above or below. Here you can see that there's a near 3-fold increase in the time to or a 3-fold increase in event-free survival for those patients that are below 35, with a rapid and a sustained increase in the risk for heart failure onset in patients after acute myocardial infarction above this threshold. Mechanistically, there are data now that show that concentrations of ST2 at the time of myocardial infarction are associated with more transmural necrosis as well as worse microvascular flow. And interestingly, treatment with anti-remodeling therapy after myocardial infarction with a mineralocorticoid receptor blocker, in this case eplerenone, not only was more effective in patients with an elevated ST2, it was only those patients with an elevated ST2 that had any benefit from treatment with a mineralocorticoid blocker after acute myocardial infarction. So these data are looking at the effects of treatment with eplerenone in patients with an elevated ST2 in yellow versus placebo, versus placebo in red. And those patients with an elevated ST2 treated with placebo had the most forward ventricular remodeling, whereas those patients treated with a mineralocorticoid blocker after myocardial infarction had no such progressive remodeling. So once again, ST2 predicts ventricular remodeling in multiple disease states, in this case, acute myocardial infarction, and really appears to predict the benefits from anti-remodeling therapy quite substantially. Now, there are other disease states where ST2 has been associated with risk, including valvular heart disease, where ST2 concentrations also predict risk in patients with aortic stenosis or mitral valve disease. Those data are still somewhat more preliminary, but I think as the future develops, you will see more and more value with respect to the role of ST2 in such patients. So in patients with acute coronary syndromes, we recommend measuring it on admission. We don't necessarily have data about serial measurements, so because most of the data in acute coronary syndromes is really based on admission, and that's where most of the damage to the myocardium occurs, we think that that's probably all you're going to need, at least for these patients. The goal value is less than 35. Again, for rising values, persistently elevated values, once you're in the office, these are patients that are very likely remodeling and would benefit greatly from anti-remodeling therapy, including mineralocorticoid receptor antagonism, further adjustment of beta blockade, ACE inhibitors, and indeed, after the Paradise study, possibly the addition of sacubitril valsartan in acute myocardial infarction. So I was given just about 30 minutes or so to complete, and I wanted to make sure I stayed on time. In conclusion, ladies and gentlemen, ST2 is a major prognostic biomarker that's associated with tissue fibrosis in the vasculature, in the pulmonary vasculature, as well as in the myocardium. It's associated with myocardial remodeling and ventricular dysfunction. Concentrations of ST2 are detectable in nearly all, if not all, normal subjects. And when elevated in an office-based subject without obvious heart failure, an elevated ST2 value above 20 predicts the risk for future heart failure. These patients should be viewed as high risk. Across a wide spectrum of heart failure, those patients with acute heart failure, those patients with chronic heart failure, those patients with an acutely injured ventricle after myocardial infarction, ST2 concentrations are among the strongest predictors of ventricular remodeling and are additive and often better than other biomarkers for predicting future heart failure or death. And lastly, therapies for patients with heart failure appear to reduce concentrations of ST2. And when we see those reductions in concentrations of ST2, a patient's prognosis is improved. So for all these reasons, we're actually quite enthusiastic about the role of ST2, and with more widespread ability to measure it, we see it playing an increasing role, not just in clinical trials, but also in clinical care. So with that, I'd like to thank you for the opportunity to speak to you this morning, and if there are any questions, I'd be happy to take them. Thank you very much.